while we are getting everybody settled, there was few questions left from earlier. I really will ask Dr. Peter Libby. The question was, how do you address elevated Lp(a) in patients with no other risk factors?
Lp(a) is by itself a very potent cardiovascular risk factor. It's causal, as shown by not only observational epidemiology, but by very concordant human genetic studies. I take it very, very seriously. Everyone, according to the European guidelines, and me, should have a measurement of Lp(a). It's very stable in adult life, so you should get a measurement because you'll pick up people with high Lp(a). It's also causal in calcific aortic stenosis. It is the skyscraper in the Manhattan plot of the genome-wide association studies of aortic stenosis. Fortunately, because we've had no proven or really effective pharmacologic therapies in the past, we have 2 RNA therapeutics that are in clinical evaluation currently. We have an siRNA and we have an antisense oligonucleotide, which is targeted using the GalNAc strategy, so you can decrease the dose and markedly reduce some of the adverse effects with first-generation RNA therapeutics. So the horizon is bright. The trial which is underway is called Horizon with the ASO, the antisense oligonucleotide. So please, if you see a patient with coronary calcification or coronary disease and calcific aortic stenosis, grab an Lp(a), and you should do cascade screening when you find a patient with high Lp(a). You should ask them to discuss it with their offspring and siblings because there's a very strong genetic codominant transmission of high Lp(a). So this is a very important risk factor. It's one that's becoming actionable, and I would definitely pay attention to it, even if there were no other cardiovascular risk factors evident.
Fantastic. Great. This is a question always comes up. So now actually, when Dr. Narula was looking, Dr. Narula was answering the questions, Dr. Liran Blum, he has asked numerous, the top questions to everyone. And here we have 2 questions. One for Dr. Fry first. COVID has indeed changed the conversation. Payers often use the term value to help motivate changes, such as in value-based purchasing and managed care agreements, etc. However, seems that the only true benefit is to improve the bottom line, i.e. decrease cost, rather than actually proving that any of their proposed changes are clinically meaningful or improve patient outcomes. What are your and ACC's approach to these payer changes in trying to focus the transition to true value, patient-centered, clinically meaningful, which I think would then help get physicians to support these transitions as well. As you remember in your talk, you did say, the patient-centered is a very common term. Everybody wants to use it. But what does this all mean? So I think it's a very intelligent and varied question in this COVID era.
Yeah, a very tough question, very pertinent one. So there's a lot in there. I guess I would say that what true value is, as is intimated, is not just reducing cost. It has to be about improving outcomes. And in almost every instance where we have looked at improvement in quality, it has secondarily led to reduced costs. So focusing on quality outcomes, very important. Second thing, and key to the issue of patient-centeredness, is asking the patient, what is the value to you? You know, that's what it, in many cases, it all comes down to. Functional capability, quality of life, ability to work, all of those very important things. So that requires us to incorporate patient-reported outcome measures into everything that we do. That's a goal of the guideline optimization and also the registry optimization that's going on among the college right now. So I think if we can ask the patients what value means to them, if we can understand that doing a better job, getting a better outcome is what ultimately leads to lower costs. And the last part of that question that I think it implied was, is this just something that payers are focused on in terms of reducing their cost, maintaining their financial health? That begs the question regarding the payment system. I think as we move to a risk-based approach of paying for healthcare, we will do things that improve the quality and lower the overall cost of delivering that care, and patients will be the ones who will then decide whether this has value to them or not.
And as you showed also, there will be less medical care cost, but insurance companies, their bank balance keep going up because they didn't decrease any premium to the patients. Patients required less medical care, less expenditure, but there was still remain discordant, which should be that if you're using less medical care, then should have given 10% or 15% reduction in their premium.
Yeah, I think time will bear that out. I'm sure if you were an insurance company executive, you would say, well, let's see what 2021 and 2022 do in terms of will there be added expenditures that they'll have later on, but that remains to be seen.
Okay. All right, let's continue. I'm still on the same questions from Dr. Blum. Now, thank you, Dr. Mehran. Seems there is some conflicting data regarding superiority of specific P2Y inhibitors, i.e. ticagrelor versus prasugrel, and perhaps less likely clopidogrel. So if we move forward with monotherapy only post-PCI or ACS, do you suggest a preference of one or the other, ticagrelor or prasugrel, assuming no history of stroke? Seems ESC is moving forward with monotherapy, dropping aspirin, faster than ACC. What do you think that is?
So first of all, thank you for that question, especially regarding ticagrelor versus prasugrel. There's been one trial, I saw React 5, where there was a head-to-head comparison in ACS patients of ticagrelor versus prasugrel, where they designed the study to be superior for ticagrelor and came out that, in fact, prasugrel had a better reduction in ischemic events in acute coronary syndrome patients. And it was a dilemma when you look at that, because if prasugrel would reduce ischemic events, then it should increase bleeding, because it just the math didn't work when you look at it, because the bleeding actually looked to be in favor of prasugrel as well. It was like a wonder drug, reduces bleeding, reduces ischemic events, and that just didn't make sense. But even so, you can't just say, oh, we are ignoring this data. I think you have to kind of think about that there could be a possibility that, especially with a once-a-day drug that patients are more adherent to, that there may be more effectiveness with that particular drug. So it needs to be tested in a prospective way, most likely in a blinded way, because we're already all very biased, and hopefully that'll take place. But that doesn't talk about monotherapy, and I think where we are now with P2Y12 monotherapy, I'd be very reluctant to go to clopidogrel monotherapy if I don't know my patient is responding to clopidogrel with a very, very large ischemic burden. So if I were to do that, I would want to be testing. And if they respond to clopidogrel, it seems like that might be okay. Prasugrel monotherapy has never been tested, but I can't imagine that it's going to be different. And the only drug that has been tested for monotherapy in a prospective randomized trial with really good, good results, no change in ischemic events, reducing bleeding, is ticagrelor. So I hope that answers the...
Yep. And the other question is, why ESC guidelines, it was the follow-up question, while ACC so lags behind
No,
of the
ACC
trial, and
doesn't
ESC
lag.
keeps coming with the guidelines.
Let's correct Dr. Blum that ACC doesn't lag behind. We never do. ACC is doing its job. We work with the American Heart Association as well as SCI, and we put together guidelines in a very, very different way than our colleagues in the European Society of Cardiology. Now, having said that, we all know that the ESC group does a beautiful job. They just get to the nitty-gritty. They bring in the experts regardless of their conflict of interest. They just put them at the table and they trust them to put forth, because these are the great experts. The difference in the American guidelines is that all of the experts who also, like myself, are conflicted, we don't get to vote. They're very rarely, we have to have people with no financial conflicts because of the perception of the conflict that could muddy the water. And that has always been the flag that I think we're very proud of, that we're separating ourselves from industry. But I believe, and we were having a discussion over lunch with Dr. Libby, that there has to be a middle ground. We absolutely must be thinking about the middle ground, and that's part of the guideline optimizations that we're looking to do, because we need to be facile, nimble, able to come forth with the best evidence, with our best experts that, by the way, have conflicts of interest. So we need to be able to put forth the evidence.
I mean, there's no question in every aspect. Keep quoting the European Society guidelines, and rarely even PCI guidelines. We are 8 years ago, then they keep a little bit of focused guidelines.
It's exactly 10 years since the ACC has put out a PCI guidelines. They will be coming out soon. But also remember, the process is a lot more different. It's much more, there's a lot of check, overcheck, recheck, public viewing, anybody who wants to say things. It is a tremendous, and we have to get all of the societies to say, yes, we agree with this and we endorse this. And imagine when you get like 6 societies to endorse a guideline when there are conflicts that have nothing to do with industry, but surgeons versus interventionalists kind of thinking about different things. Maybe Dr. Fry wants to
of course.
say a word.
Yeah, just to Dr. Bloom, I would say we're working on it. Number 2, the redesign of how the guidelines are rolled out, as Roxana alluded to, is changing to be both more useful and timely. So to be produced in a modular fashion so that on an annual basis the guidelines can be updated without having to rewrite the entire document, to bring forward new science while still maintaining the objectivity of avoiding the conflicts of interest. So.
Okay. And we're ready. 2 very important questions again from Dr. Blum. Excellent presentation, and thanks for the informative presentation. One is, any comment on the incidence of significant mitral stenosis post-clip and its management?
Yeah, I mean, having done this procedure for so many years, that's possible. But before we release the clip, we always have to make sure the gradient, we measure the gradient. So we rarely release the clip where we think that there could be a gradient and can cause a mitral stenosis. But if it happens, because it can get fibrosed and a lot of things, but what can happen, which I never mentioned, is actually detachment. That is something we do see and can happen, giving rise to more mitral regurgitation. So in any of this, both situation, we may have to go back and get a surgeon's help again.
Any particular gradient which you will not release the clip? Because as mentioned, before releasing the clip, you grasp the leaflets, and before releasing, you check the gradient. And what is the gradient threshold that you say, well, now I don't want to change mitral regurgitation to mitral stenosis, which may be even tough to treat?
Yeah, which a gradient of about 7.
Yeah, so 7 is the cutoff.
So
if you made a more than 7, you will not release it, it will come out as an unsuccessful procedure, which is okay.
No, yeah, nowadays what's happened, like I showed you, we go with 2 clips. So it's rare that we will do 1 clip. So we'll do 1 clip, the gradient usually about 2 or 3. If when we are ready to release the second clip, then the gradient, jumps up to 8. That's the time we'll say, okay, now let's not release the second clip. So we will just leave the person with 1 clip. So moderate to severe MR has now become mild to moderate. With the medical therapy, they still do very well.
Okay. Now then, another question. You mentioned post-clip prognosis based on TR severity. So is the presence of significant TR, either moderate or greater, is a contraindication to mitral valve clip to begin with? Can you comment on the role of mitral valve clip device for tricuspid valve repair as well?
Yeah, interesting. So actually it's the other way around. So if you have severe TR, I'm just saying, if you have a patient, you have moderate to severe tricuspid regurgitation, and you also have moderate to severe or even moderate mitral regurgitation, you always want to fix the left side first before you think the right side has to be fixed. So that is how it goes. So fix the left side, see how the patient does. If the tricuspid regurgitation, so the one slide that I showed you, the residual tricuspid regurgitation is after treating the mitral regurgitation. So those are the patients who do poorly. And right now when we are doing for TriClip, which is triluminate, that is the entry criteria also. Anybody above moderate mitral regurgitation cannot be part of the trial. So treat the left side and then come to the right side.
So there basically the tricuspid clip is also available for selected patients. Yes. And so. Okay, now Roxana, for you back again. Should clopidogrel be used now instead of aspirin for primary prevention approved patient? It is by some number, but doctor's name is not there. The clopidogrel instead of aspirin in primary prevention.
Primary prevention hasn't been tested. I wouldn't even dare to go near it. So for secondary prevention, going to a single antiplatelet therapy, it's something to consider instead of going to aspirin indefinitely to have clopidogrel. But I'd still want to make sure they're actually responding to clopidogrel, even though there's never been a trial that has showed that guiding and using platelet function testing helps you. But I still want to know that they're actually responding. If I'm going to put them on a drug, I'd want to make sure that it's actually working.
So, and then other question is, so if I understand correctly, this is another doctor, that if you have non-obstructive CAD, we should not be suggesting using aspirin and instead use other means of anti-inflammatory ideas such as statins, and correct?
So in a non-obstructive CAD, but there's still some CAD, you still have CAD. So it's not like you don't have, I mean, there's still atherosclerosis. So I don't think that that's the case. And I think if you document that there's some CAD or PAD, that's no longer primary prevention. It's more about, secondary prevention for looking for, not having MI or stroke or et cetera. And I think to me, that's a secondary prevention. We see a lot of patients with non-obstructive disease, and we actually get quite aggressive with them, especially if they have risk factors such as hypertension, diabetes, smoking, obesity. So lifestyle changes, and if they have a high C-reactive protein, which I measure all the time, as well as Lp(a), then I really get very aggressive with those patients, and also the triglyceride levels. And so now we have so many great therapies now that we could really address many of these issues, that I believe the antiplatelet therapies are there for them as well, but we shouldn't not think about these other therapies.
Okay. Dr. Fry, how is ACC plan to circumvent insurance barriers for pre-authorization of FDA-approved drugs that the insurance industry denies the patients? And we know that with the PCSK9 inhibitor, it's become quite tough in the past, now getting better, but still the pre-authorization of the FDA-approved drug for that indication, and what is the ACC takes the stand on?
Another easy question to respond to. So this is an issue that confronts not only cardiologists, but also internists and everybody who has to deal with prior authorization for any well-developed therapy. This is being addressed at a national level, although most of the regulations around pre-authorization occur at a state level. And there are examples across the country in Ohio, Kansas, Texas, where successfully advocacy led by ACC at a state level has put in place legislation that has been, I won't say curative, but has been an improvement. Probably the most important of which has recently been in Texas, where the concept of gold carding, or demonstrating that you have been a good actor in terms of prescribing medications over a period of time and subjecting to an annual audit to look at your performance. That's probably the way forward. Again, I think much of this will change as the payment system changes, when it becomes such that you hold the risk in terms of taking care of the patient, you will determine what is the best therapy for that patient. But in the time being currently, this is front and center for state-level advocacy for the college, and also nationally. This was part of our legislative day conversation with national legislators this past weekend, too.
I just want to underline the work that ACC does on advocacy. It's an incredible, we spent this entire week actually online with Senator Chuck Schumer's office, all of the local and state representatives. We have ACC volunteers that are completely committed to talk to them about all of these issues and to make sure they understand what it is that we're going through. ACC is working tirelessly on this, and advocacy is an incredible arena that ACC has worked on for the last many decades and has helped physicians, not just cardiologists, that even the general physicians who are feeling these pains, to be able to endure them a little bit better by having our state legislators and local representatives understand what it is that's going on, because a lot of this is lost in translation. And when we get in front of their offices and tell them that it's through telehealth that I'm able to actually take care of some of these elderly patients that cannot come into the office to see us, they better understand that they shouldn't be getting rid of the government subsidies that they're doing for some of the telehealth, for example. It was really enlightening. I can't tell you how important that is. And it's the money that the membership is who's supporting this. So if you're a member and you haven't paid your dues, pay your dues. It's really, really important for ACC.
There are two other things I would say. So, and those are superb points. There's actually a tool online on acc.org. It's called the PAR tool, P-A-R-T-O-O-L. And it is a database that captures problems with prior authorization. Because that's what we need, is we need data to be able to go to legislators and regulators and say, this is the % of time that we run into this. Anecdotes don't work. We need to bring data. So that's something you can do. The second thing is, again, at the state level, as ACC chapters, is to go to the State Department of Insurance and to work directly with the regulators, the people who have put in place the regulations. That is as effective, and that's what led to the changes in Texas, rather than having to rewrite the laws.
Now move to the question for you. One is that there are ACE inhibitor and hydrochlorothiazide or diuretic combination, but any of this aldosterone receptor, mineralocorticoid receptor blocker combination will be coming in the market soon?
Yeah, so those are in development of combinations with, for instance, the SGLT2 inhibitors as single pills. That will certainly help with ease of use in terms of simplifying dosing for chronic conditions like heart failure and chronic kidney disease. I suspect, though, that cheaper versions of especially some of the generic therapies like spironolactone will still be the most affordable option, because the newer combination therapies are going to be branded and likely more expensive.
So now we have two last questions. It has been a so interactive session, superb. One for Roxana, one for Anu. One is actually Dr. Graf. The earlier few questions have been asked about the clopidogrel alone, and so that is aspirin for carotid disease. And how severe does the carotid disease have to be as a primary prevention?
Yeah, it's a really good question, and I think I'm putting my patients, a lot of them, on aspirin and sometimes in combination with clopidogrel for prevention of stroke, because the stroke prevention has been quite strong there. So I've done some dual antiplatelet therapies in those patients. So
because Dr. Fuster this morning emphasized that even calcium score versus carotid intimal thickening, they're kind of neck to neck in terms of risk factor prediction, as a baseline risk factor for the future event in healthy people. So carotid thickening or carotid lesion, even mild one, are coming up.
And I think, I'll just add that I think a lot of the questions have the same flavor of the blurring the lines between primary and secondary prevention, in that as we disseminate more sensitive tools, especially imaging tools, to identify atherosclerosis at an earlier stage, secondary prevention therapies like aspirin and statins will be indicated for those patients.
Exactly, because I think once you make the diagnosis, it's no longer primarily preventing. CAD is an event, as far as I'm concerned, so, or PAD, or any.
Therefore, answer is that even once you found even a mild degree of obstructive disease in the carotid, it's a kind.
Well, I'm quite aggressive. Not, you know, as soon as I see any of those, I'm very aggressive on baseline risk. So I look at all of the risk parameters, making sure they're hypertension, diabetes, hemoglobin A1C, all of those other parameters are taken care of. Doesn't always have to be antiplatelets, but then antiplatelets when you have a pretty high-risk patient.
Beautiful. Okay, last question, Anu, for you. That are there any cases that you would implant left atrial appendage occlusion at the time of mitral valve clips?
We ideally don't do that, but there have been requests actually saying, because they think we are very close by when you're coming out to another procedure and come out. But there are two ways you can deal with it. One of the indication is that you have atrial fibrillation, concomitant atrial fibrillation, and patient cannot take anticoagulation. So you want to do left atrial appendage closure. So if that is there, yes, we do that procedure at the same time. But if the condition is that paroxysmal atrial fibrillation now has mitral regurgitation and we're doing a clip, that's the kind of case we would likely not do it. We hope by doing a clip that, LA size or paroxysmal AFib will not recur.
Yeah, and actually just to emphasize to the way our reimbursement pattern is in America, no matter what you do, the assignment goes to the highest DRG. So you did a mitral clip, and you do any other procedure with mitral clip, left atrial appendage, it will be part of the same DRG. So hospital will end up losing money on those cases, the way system is here. Compared to outside, these combined things are done at the same time because there's additional separate cost. So this is one of the reasons. So yes, there are some trials are being done even at the time of the tower, that should you put a left atrial appendage the occluder. And so that trial is ongoing at present, but key issue remains that combine same, that PCI and tower, we rarely do. Why? Because of the same reason. It's ultimately, there are some safety also issues, but more importantly, combined procedures are not commonly done. With that note, I really thank all the speakers for this early afternoon session. Fantastic job. And our audience was the very, very, excellent questions with Dr. Liran Blum, who really attended and spoke every lecture, and I saw that he had asked right from the morning very intelligent questions. Yes. So we definitely have to get him a special iPad, even if he's not there. Those who are here will get the iPad in few minutes once you are done with the last presentation.
He can send us more questions through the iPad.
Yeah.
Okay.
Be careful.
Thank you.